So I think I've probably introduced myself several times to everybody, but I'm Lydia Green. I'm one of the paediatric neurologists working in Leeds and heading up the North IWMD Centre for Paediatrics. It's always tricky to know where to pitch these ones because I'm going to talk to families that know everything, inside out, back to front. I'm going to speak to some people who've got a diagnosis and never been told anything, and then a lot of other people who've never heard of the disorder. So hopefully we'll catch a few bits throughout it, and mainly if there's questions to ask, please just feel free to jump in if I'm not saying the right things to you. What I thought we would do is just talk a little bit about AGS and the type 1 interferonopathies, because they are words that are now heard, but I don't think they always are explained. We're going to talk a bit about the challenge with the neurological presentation of AGS, and then trials, treatments, and most importantly, the impact that they have on patients, because that's really what we're here about. So AGS and the type 1 interferonopathies. So these are rare diseases due to variants in now 9 known genes, and that's been growing year on year for the last sort of 10 to 15 years. And all of these genes, although they work differently, they're all involved in the way bodies senses DNA and RNA. So you get bits of DNA and RNA floating around in your body, and you've got mechanisms to recognise, are they part of me, are they mine, or is that foreign material? Is it virus, is it bacteria, is it bug? And it's in that sensing pathway that they've all got their action. So usually they're recognising foreign material, and if that's a problem, activating your body's immune response to that to flag it up and get your body going to deal with that system and that problem. But what happens then if you've got problems with those genes, and instead of recognising virus as virus as foreign, you're recognising self as foreign. You're then over-activating and inappropriately activating your immune system that then leads to damage to itself going forwards. So we now call these the interferonopathies, and this is a massive graph chart where all of our 9 interferonopathy or AGS genes are involved, but actually it's a bigger pathway. There's lots of things involved in there, and right at the end of it, we've got interferon. So interferon is a protein that we shouldn't be making unless we want it to go and attack a virus in the body. But because of the abnormal signalling, we're getting overactivation of interferon. It's really important that we see how many steps and proteins and enzymes are involved in this pathway, because that shows how complicated a process it is, and we're not looking at one gene target within that. We're looking at 9 gene targets within a much bigger system, but they all come together to cause the same end result, and it's that end result that causes our problem, that causes AGS, but also causes those other interferonopathies. And I think at my last count there were probably 37 disorders within that group, of which AGS is one of them. So there's lots of things that affect this pathway, and some of those have brain problems, but some of them don't have brain problems, and their skin and their inflammation, and there's other aspects to it. So it's one part of a bigger picture. Now, what does this excess interferon do? So we've switched on the system when we shouldn't have done it. It's overactive, it's recognising ourself as foreign material and it's attacking it, and then we have lots of excess interferon. Now that's neurotoxic, so it's damaging the brain, but most specifically the white matter. So that wrapping, covering or sheath on our nerves that's helping pass those messages, step 1, that's what it does, but it also maintains the health of the nerves and the axons in our brain. So if you take the myelin away, it's like nibbling away the rubber around your electrical wire, so you're not going to pass the messages, it's fizzing away and not passing that message on. But actually, beyond that, the nerve itself then becomes damaged over time, because myelin, yes, passes messages, but it also maintains your nerve health. So there's a double hit. You've got that first bit where your myelin falls off and is damaged, and then you've got that longer term damage to the underlying axon and nerve, and that's why we see that progression of symptoms over time. So you see your first bit where your myelin is damaged, and your later bit where your nerves and your axons are damaged, and that's why we see these symptoms progress over time when we think they're not always a progressive disorder. Now, the neurological presentation of AGS. So AGS is probably one of those things that comes through our MDT relatively frequently. In terms of rare disorders, or very rare disorders, it's not as rare as some of our other ones. And unfortunately, we look at a scan and go, the scans I can say, that's an Alexander's scan. AGS, anything can look like AGS. It can look like stroke. It can look like some of our mitochondrial disorders. It can look relatively normal. It can look like infection. And so it's really challenging, because there isn't one thing I pick out and think, this is my AGS patient, I've got it. And that we see that on the outside as well. So your classical AGS presentation, so that was described by the initial Paris team, they saw babies who were presenting with neonatal infection. So babies that were born on the neonatal units, they've all got infection. And then they realised, actually, there's families where the families have babies with neonatal infection. Well, that doesn't make sense. They're not carrying this infection, that each family member is then getting that, so there must be something else. So although individually the children had been treated as having infection, it was only when you looked at the family history over time you went, there's something else causing this. And this was really the first monogenic disorder where they thought, or a mimic of infection, but genetic disease causing an infection mimic, and our classical AGS is still described as that. So neonatal disorder, feeding issues, fevers, looks like a meningitis type picture, and then you get that progressive neurodisability and neurodevelopmental impairment going forwards. So we still see classical AGS. We have later onset AGS, usually over the age of 1 year, and they can present in a couple of ways. Sometimes we've had a really early normal development period, and then you get this crash and the bus comes along and hits your family because suddenly you lose those skills, suddenly your life changes. Sometimes it's a bit slower, and actually over time the development has probably been a little bit impaired for a while, and then you see that progression and they're being picked up and investigated. After that presentation and regression with some loss of skills, our children tend to look very, very similar to our classical AGS patients. So although they come at us differently, when we look at them over time, they look similar and they have similar challenges and problems. But then we've got this other cohort of patients. So our dystonia and striatal necrosis, that's one of those 9 genes tends to cause that. The spastic paraparesis, so children that are cognitively intact, they're still talking, communicating, often in mainstream school, but their main problem is the motor problem in their legs. The onset's often later and progresses slowly over time. And then the cerebrovasculopathy, so these are the ones these come with, again, a specific gene, and they look like they have strokes, and they have strokes over time. Some of them are big, some of them are little, and their scans look different, and they look different. So you can see the picture of challenge. If you get a patient that walks through your door, they can look like any of these things, and their scan can look like almost anything. You have to be thinking about AGS to test for it, and to know to look for it. And only with that, we understand a lot about the pathway, but if you never think about it in the first place, you don't get a diagnosis. So, genotypically, all the genes can cause pretty much all of the things. Phenotypically, all our patients can look different. We can have a family where 6 family members are affected with the same gene, and they all have a different type of AGS disorder. So even with a family, you can have exactly the same spelling mistakes, and you look different, which makes it really, really tricky. But there are some common core symptoms. So things about when we can talk to families, can I tell you what the next 5 years are going to look like? No, I would be lying if I knew, and I said that. But I can tell you things like spasticity is a problem for the majority of our patients. Dystonia is the problem for the majority of our patients. Most people have scan abnormalities, and most people have intracranial calcification on their scans. Not everyone, but if we start with knowing what's common, we can then think about what's less common and prepare you for those. So why is understanding the pathology really, really important? I think over the course of the weekend, we've talked about rare disorders, some of which we understand much better, and we've been able to put pictures up of what happens, and some of which we've got a gene name for, and we have absolutely no idea what that gene does, but it causes a leukodystrophy at the end of the day. We actually know a huge amount about AGS, and it's probably one of the most exciting programs in terms of disease development and progress over the next 5 to 10 years, because we understand so much about how it works. We understand the pathways, and once you understand a pathway, you can think about how to modulate that. I think it's really careful that we're not using descriptions such as cure, because even with the best therapy, that's probably not where we're looking in the short to medium term. In the longer term, maybe, but now let's not mention that. Let's talk about disease modification that focuses on quality of life, that limits that progression, and actually holds us in that good place, and hopefully prevents us getting to the worst places. Now, why is it challenging? Because although we can understand what happens in a disease course, we can't turn back the clock on your myelin and what's happened in your brain. So all the therapies that we are in development, and there are therapies that are prescribable in the NHS, there are therapies in trial, there is a lot going on for AGS. A lot of these are looking at turning off that overactive inflammation, the thing that's causing damage. They're not talking about repairing that damage that has already happened. And it's it's difficult because we're talking about when to get in with these therapies. We've got to get you at the right time to know that we can make a difference. So at the moment, there's 3 main groups. I don't know if you can see, my cursor's probably miles away. Can you see my cursor on there? I can't see my cursor on here. So I'll come and point because I can't quite work. So the therapies at the moment, we can focus on really 3 places. So in this top box, you can stop the over-signalling. So we're not sensing ourselves as foreign, and we're not kicking off the signalling with the top box. So that's one thing. There are treatment trials currently looking, and they're using drugs that have been used for really long in HIV, so they stop you over-signalling accidentally. The bottom box is then trying to block the pathway. So yes, we've over-signaled, we've kicked it off, but now we're talking about not activating it. So we're not going to initiate it, we're not going to activate it. And a lot of the trials have also looked at the JAK pathway, so this final step here, and not actually, even though it's activated, initiated, we're not going to activate that pathway, and we're going to block it there. And there are trials with the JAK inhibitors, and there are treatments prescribable in the NHS with the JAK inhibitors. And then the final step is blocking the action of interferon. That's a bit trickier, because we want interferon to do its job. It's an important part of our body, so we don't want to block it for everybody, but there are 3 separate steps we could potentially modify when we're talking about treatments. Why is it important? Because actually we understand the AGS natural history relatively well for some of our rare diseases, and we know if we're not treating them, the mortality is about 20% in the early stages, and of those children that survive their early presentation, 74-75% have got significant neurodisability. So that means everybody's affected is affected significantly. And for families, if we can change even some of that pathway, we can impact that. But it's a good place to start, but it's a hard place to be at the moment, because I think this will change quickly, but I'm not sure it changes now, and that's a really tricky. It's easier for me to say there's nothing going on in your disease, because I'm not putting hope in that way. Actually, there's loads going on in this disease. It's just how quickly we get it there, and what does it mean for our patients. So, sorry, I didn't need to point. I've put pointers on that I forgot about. There we go. Sorry. You do these things about 3 a.m. sometime and forget. So, what's actually much more important than what's going on? It's about assessing the impact on our patients. So the biggest challenge is getting in with treatment at the right time to actually make a difference. Waving a treatment around when it isn't going to change your day-to-day is not just unfair, it's cruel. Because actually, families are wanting these things, they're desperate for these things, and we need to be really careful about how we pitch where we are, because we want hope, but we want also to be realistic and honest, and that's important. So from the natural history studies, about 20% of patients or 25% of patients have a period of being asymptomatic where there is a chance to catch these patients. Really now we're probably talking about patients in the future for the biggest impact, but there is a time point, and that's important because we're talking about disease and having the biggest benefit. We want to try and catch it early, before that damage has happened, before that myelin has fallen apart, before the axon has had secondary damage. But there is scope for that in AGS for at least a fifth or a quarter of our patients. But we then need to know what happens with the disease course, so we can compare when we've got a treatment. Is it making a difference? Is it worth it? Because often treatments take a lot of toll on a family, so actually, is it worth going down that line? Now, when the first AGS was first described, it was described as a progressive disorder. I think over time, that's probably changed. I think there is a lot of thought that in the first 12, 18, 24 months, you have that initial hit, the profound deterioration, the damage. But actually, the disease course is relatively static beyond that point. Now, that doesn't mean our patients don't have more problems coming with time, because symptoms change as children grow, the brain changes, but actually in terms of the period of damage, the period that we can change with our treatments is probably more static than we thought when it was first described in the 80s. And that's important to understand, to think about where the place for our treatments is. We also then need to think about how we assess the outcomes of our treatments. Now, because there's been so many trials, they've looked at lots of different things. And what we've learned from that is if you've got the chilblains, the fevers, the joint inflammation, it's really easy for me to say, you've had some treatment. What's happened to your chilblains, your joint inflammation with that time? If you've got the neurological features of AGS, it's much harder. How can I tell you after 6 months, 12 months, 24 months of treatment that you are better now? What marker can I put on that? And there's loads of assessment scores, so the ALD and the MLD trials have scores that they're using for their patients. They're very specific. But when we've got such a heterogeneous group of patients that all look so different, for me to say we can only treat 5 patients because we've not got many, and they all look slightly different, and at the end of 24 months, has it made a difference for those 5 different patients? It's really challenging. So there is no clear answer, despite the trials that have gone forwards, and the trials have had groups of anywhere from about 5 to 35 patients. They've been small, but not tiny, but not big trials. And overall, the nice perspective on is that overall there is favourable evidence that they have a positive benefit, but there's not a statistically significant evidence. And that's important for taking big things forwards in big groups. So that means NICE we were pleased because NICE said, yes, you can prescribe some of these treatments, which is a big step forwards, but it doesn't help everybody, and it doesn't help us when we're discussing with families saying, is this right for you? I have patients that we'll talk about treatments, and I'll pause, I'll talk back to that. It's important to think about that because when I speak to families, we then need to evaluate the potential benefits with the risks. Now, if I can't tell you what this treatment might do for you, how do you possibly put that into context? I can explain the blood tests you have to have, the side effects of the treatment, the risks of the treatment, and there are risks of these treatments because they're doing big things in important pathways of your body. But if I can't promise you that there will be a response, or even that I know how to properly monitor that response, that's a really big decision for families. I've got quite a lot of AGS families, some of which have chosen to take treatment and some of which have chosen not to, and I think neither of those is right or wrong, because actually it's a really individual decision. And if I thought this was a treatment that would make things better, definitely, then I can push that. If I don't know the answer, I can't push that, and it might not be right to. And that's where we are, and it's important to be honest about that. So very quickly, let's talk about what we can do on the NHS. So baricitinib is the first NHS-approved treatment for interferonopathies generally. So it's not called AGS specific, but AGS is within that group. It's a JAK inhibitor, so it works in that bottom box of the pathway. So we're initiating the pathway, but it's stopping the interferon and blocking it from being made. It's got wider impacts on the immune system and its response to viral infection. So yes, I want to switch off the overactivity that's causing the neurotoxicity of the brain, but it's also going to affect the way that your body fights infection more generally. So I'm offering you a treatment. I know how it works. I know that it works on the interferonopathy pathway that we see in AGS. I don't know how it changes the neurodevelopmental outcomes for all our patients, but I do know that it has side effects in terms of its viral profile. It makes you slightly more susceptible to infections. In studies, it is shown there is a slightly more higher risk of blood clots. These can be very serious things, so it can't be taken lightly. Now, in terms of the skin changes, the chilblains, the trials are really positive. I've got one child he started this month, and I've been desperate to get him on for ages because his chilblains are so bad, I cannot get him in his splints. He is still ambulates with support. I can't get his splints on. His tone is getting worse. For him, I think this will be life-changing. I've got other patients that are on the treatment who Mum was delighted for the first 6 months because she thought for the first time ever she'd got a little bit of head control, and that's her being on her shoulder, and she started to lift and look. That's the first time we've ever got there, but that's a small thing on paper, a big thing for them. She's been poorly since. I'm due to see her soon because I think she's probably lost some of those skills again. So she's had the benefits of what they perceive as benefit, smaller, but still beneficial for them as a family, but there are risks with it. And it's harder for those families to know if that's the right thing to do. And if a big problem happened, would I regret that decision? I don't know yet. And I think that's really tricky for me and for families. There's no good place to be. So I think this is still a family discussion. This is not my decision. This is something that every family is different, and I think we have to be open about the things we can promise you and the things we don't know yet. I think if people don't want this, I think that's absolutely fine, and I think if we do need it, then what we're doing locally is making sure that we're seeing you regularly and trying to assess where you are, because at 6 months, 12 months, if we don't think there's benefit, we should tell you to stop it. Because sometimes having a medicine and clinging to that medicine with the hope it will change things, if we're not seeing any improvement, your risks probably aren't worth it, and sometimes families can find that hard to hear. So I think part of our job is to, if you're on it, help you say it might not be right for you and to stop. Because I know that in that circumstance, if something happened, I don't think I would ever be able to forgive myself for that. And I think it's that back and forth decisions and discussions that are really important in new treatments in rare disease. I'm going to be shouted at in a minute, but I know the speaker after me is not here, so I can keep going for 2 seconds longer. So access baricitinib, so it needs to have specialist MDT approval, so it needs to come through the White Matter Service, we need to be approving it, and we need to be discussing it. This isn't a one-job consultation, and the reason for that is because the evidence isn't clear enough that one person could be making that decision. We need pre-screening investigations, so is it safe to start? If your immune system isn't cracking, I'm definitely not going to put you on a treatment that's going to make it worse. You need monitoring during treatment, so is it safe to continue? And that's quite invasive. You need bloods at 1 month and then every 3 months. You need your eyes checking, you need your heart checking every 3 to 6 months going through. And then we need to assess those outcomes every 6 and 12 months and decide, is it worth continuing? Because you pay a price for this. Even if it's just blood tests, that's a price, that's appointments, that's trips, that's having blood tests. So is it worth it for you as a family? And I'm really happy to support families where they think it is, but I'm also happy to support discussions where it might not be, and that will be a difficult decision for families, and we can help them through that process too. Right, there are loads of trials going on. There's trials recruiting and opening next year. We're really lucky because we have Professor Crowe in Edinburgh, who has been one of the mainstay creators of AGS research, and he's worked in the Paris team that is also the leader, and there's Philadelphia trials, so there are trials. We really thank patients because I think most trials at the moment probably aren't going to change everything for you guys, but I think in the next 5 to 10 years, they will, I think, save the lives of some of our families, and I think that's a really hard place for you to be. You're in a place of hope, and there is real hope for the future, but there's also a lot of responsibility on people now, and that's really tricky. But we do appreciate everybody that gets involved to try and move things forwards, if not now, for the future, and the short-term future, I think. Any questions? Thank you ever so much. Small group, but I've got rapturous applause. That's what that'll do.
Are there any questions for her? Yeah?
I guess I'm curious if this goes across when you think about this particular because watching your body language listening to you, is that like we're thinking about how to moderate the effect of choice? Is there a way to think about that specifically in an AGS patient versus another normal history, or how do you as a physician
So I think the challenge for AGS, so I think it's the challenges across the board. I think the specific challenge for AGS is the fact that it's just so heterogeneous. So it's really great they've got a treatment, but because we're looking at, if you do specifically for trials, you want to put your 20 patients in, you want them to look at the same at the start and the same and compare them at the end, or at least have groups within that. It's so rare and so heterogeneous, so a trial setup's really tricky, because so to prove it in evidence is really, really hard because of that. I think what leukodystrophies generally are, often our children at outset are quite neurodevelopmentally impaired, and now that's not everybody. I look after a full spectrum, but when that's the case, thinking how you are going to assess improvement in those patients, when I'm thinking whatever we do, almost all the therapies across the board are looking at stopping progress, not putting myelin back on a nerve, and that's really tricky. Now there is some research going into myelin protective and myelin regenerative projects, but they're really in the early stages, and I think that will be different. But I think at the moment, it depends on the way where you get in with treatment. So if you're starting pre-symptomatically, great, really easy to assess. But if we're starting further down the line, it's harder. To answer your question, maybe.
Any other questions?